Hello friends, this is Dr. Madhurima Ganguly, your pediatrics faculty at Global Academy of Medical Education. And we have started a pediatrics marathon series where the main aim is to complete the entire subject in a very short period of time, and we are only discussing the most high yield points and also some MCQs which were previously asked, and also we are also stressing on some one-liners or key concepts that can be asked in your future exams. Future exams signify FMG, NEET or next, and some questions are extra edge topics. We have focused on some extra edge topics because we are targeting also the INICET. So the main aim of this entire series is to make you understand the entire subject. We have already completed in the Pediatrics Marathon Series 1, Rheumatology, in the Pediatric Marathon Series 2, Pediatric Cardiology, and in the third series we have done Endocrinology and Pulmonology. So in this series we are going to mainly focus on Pediatric Nephrology. If you have not watched the previous series, please go back. They are free on YouTube and you can access them anytime. So we are going to start with the Pediatric Nephrology. So the first thing is some one-liners. Most common cause of antenatal hydronephrosis is transient or functional, okay? If it is not given in the option, then the second best option is pelvic-ureteric junction obstruction. So PUJ obstruction is the second best choice of most common cause of antenatal hydronephrosis, followed by vesico-ureteric reflux, followed by uretovesicular junction obstruction. In AIMS, usually in the INICET papers, you can be asked some sequence-based questions regarding the most common cause of antenatal hydronephrosis. So at least you should remember this too, that is transient being the most common cause, followed by pelvic-ureteric junction, followed by vesico-ureteric reflux. Now, one point regarding the embryogenesis of kidney. We know that the kidneys, which contains 80,000 to 1.2 lakhs nephrons, they ascend during development, right? And the entire genitourinary tract is developed from intermediate mesoderm. And we have the ureteric bud, which gives rise to the collecting duct system. So nephronogenesis, the entire nephrons, the genesis of the entire nephrons is completed by 36 weeks of gestation. And the kidneys, they ascend during development. Very important point, that is the kidneys ascend during development. Next is Porter syndrome. So it is a syndromic association where we have the following points. What? First is the bilateral renal agenesis, facial dysmorphism in the form of hypertelorism, epicanthic folds, there is a receding chin, okay? Limb defects. Now these limb defects are more commonly in the lower limbs than in the upper limb. Along with, there is oligohydramnios, and pulmonary hypoplasia. Even this pulmonary hypoplasia is the most common cause of death in Porter syndrome. Can you tell me another condition where pulmonary hypoplasia is also the most common cause of death? Yes, it is congenital diaphragmatic hernia. And also we can remember autosomal recessive polycystic kidney disease, where also pulmonary hypoplasia occurs. So whenever there is oligohydramnios, there is a chance of pulmonary hypoplasia. Now if you are having single umbilical artery at birth, you should always do an ultrasound KUB. Actually, ultrasound KUB is always done if you are having some midline defects, right? If you are having cleft lip, cleft palate, imperforate anus, scoliosis, congenital heart disease, renal agenesis, or single umbilical artery, we should always go for ultrasound kidney urinary bladder. right, to look for congenital anomalies of the kidney and the urinary tract. Another important thing is that if you're having a child with unilateral renal agenesis, suppose in one side the kidney is not developed, then that means there is going to be absence of ureter development on the ipsilateral side. In males, there can be ipsilateral non-development of vas deferens and epididymis, and there is a chance of contralateral vesicoureteric reflux along with Mullerian anomalies. And this renal agenesis can be associated with Mullerian agenesis, autosomal recessive polycystic kidney disease, autosomal dominant polycystic kidney disease. Along with that, we can have obstructive uropathies and Porter syndrome. Even we have got 4 types of Porter syndrome. This is beyond the scope here, but let me tell you, in type 1, type 2, type 3 and type 4. Type 4 is associated with obstructive uropathy, and in type 2 it is associated with Porter syndrome. So renal agenesis which results in Porter syndrome is type 2, and type 1 and type 2 are the cystic diseases of the kidney. So for your entrance exams, you should remember that Porter syndrome, we have renal agenesis along with lower limb defects, and there is oligohydramnios and pulmonary hypoplasia. Any other condition where we are getting pulmonary hypoplasia, the answer is congenital diaphragmatic hernia. Another thing, if you have to remember, apart from this, you can remember that autosomal recessive polycystic kidney disease. And if you are getting a single umbilical artery, we should always go for a screening of ultrasound KUB to look for the congenital anomalies of the kidney and the urinary tract. Now next one-liner, most common cause of abdominal mass in a neonate. See, abdominal mass, very important. Always read the question before you answer in any entrance examinations, because what happens, we know the answer, but whenever we read the questions we get confused and we can mark the wrong answer. So please take your time and read what is being asked in your paper. So most common cause of abdominal mass in neonate, the answer will be multicystic dysplastic kidney. See, if you just break the words, you can understand what happens in multicystic dysplastic kidney. So there are multiple cysts and it is dysplastic, right? So there is dysplasia or abnormal development of the nephrons, the functional unit of the kidney. If I twist the question and ask you, most common cause of abdominal malignancy, the answer is going to be neuroblastoma. Very, very important. I am not writing nephroblastoma, mind it. I am saying neuroblastoma. Nephroblastoma is something else. It is Wilms tumor. Wilms tumor also presents with abdominal mass, but you get to notice it usually after 2 years, and usually while bathing the child, the mother can just see a palpable mass in the abdomen. Along with there can be loin pain, there can be hematuria, and then it comes to the notice and we go for a CT scan, etc. and we find out, okay, we are dealing with Wilms tumor. But I am not telling about Wilms tumor, I am telling it's neuroblastoma. Okay, so these are 2 very important one-liners. Coming to autosomal recessive polycystic kidney disease. Autosomal recessive, so of course the inheritance is autosomal recessive. What is the chromosome? It's chromosome 6, and the protein is fibrocystin. Of course, in medicine you have definitely understood about the autosomal dominant polycystic kidney disease, which is autosomal dominant. It is usually present in adolescents or in adults, where it is of 2 types. We can have polycystin 1 gene involvement or polycystin 2, and the chromosomes are chromosome 16 and chromosome 4 respectively, right? And if you are having autosomal dominant polycystic kidney disease without involvement of polycystin 1 and polycystin 2, we can have GANAP mutation, GANAB, GANAP mutations, right? But in children, mainly we are focusing on autosomal recessive polycystic kidney disease. Of course, you will get enlarged kidneys with poor corticomedullary differentiation, and very important, it also affects the liver. So we can have hepatic fibrosis. So if and these children, they ultimately go for end stage renal disease in a very early stage, less than 10 years they will go for ESRD, and the only treatment we can go is that we can go for nephrectomy, but the definitive management is definitely transplantation. So we have to go for liver and kidney transplantation both. So one cystic disease of the kidney where we need to go for liver and kidney transplantation, the answer is autosomal recessive polycystic kidney disease, but the prognosis is very poor. So apart from cyst in the kidney, we are going to have the involvement of liver in the form of hepatic fibrosis. However, in autosomal dominant polycystic kidney disease, we'll have cyst in the kidney and cyst in other places as well. Cyst in liver, cyst in ovary, cyst in pancreas, cyst in spleen. So liver, ovary, spleen, kidney, we are going to have cysts. And apart from that, we can have some intestinal diverticulum, or we can have hernia. In CNS, we can have intracranial aneurysms, and in heart, we are going to have mitral valve prolapse. So remember this, in autosomal dominant polycystic kidney disease, what is the heart disease that you are going to get? So the heart disease is going to be mitral valve prolapse. So we are going to get mitral valve prolapse, right? So have you understood this? And also what we are going to get in the brain in autosomal dominant polycystic kidney disease, we are going to get intracranial aneurysms. And since we are going to get intracranial aneurysms, we need to go for AMR angiography. AMR angiography. Understood? Now, what is meant by significant hematuria? Significant hematuria. So, you know what is hematuria? Hematuria means blood in the urine. Blood in the urine. So, if there is more than 5 RBCs per high power field, we call it as hematuria. But here the term is significant. It was once asked in Fmge exams 3 years back. Significant hematuria constitutes how many RBCs? So remember, it is more than 50 RBCs per high power field is what we call as significant hematuria. So you need to remember this magic number 50, right? So hematuria means more than 5. If it is significant hematuria, it means more than 50. So hope this slide regarding the one-liners is very clear. Now coming to this very important image, and I discuss this image in my every class because this is one of my personal favorites. This is the grading of vesico-ureteric reflux. So this is nothing but the grading of vesico-ureteric reflux. So whenever I say vesico-ureteric reflux, 2 questions come to my mind. Most common cause of recurrent UTI in children. So most common cause of recurrent UTI in children. The answer will be VUR. And number 2, we need to remember what is the investigation of choice of vesico-ureteric reflux, or investigation of choice of the most common cause of recurrent UTI in children. Both the cases the answer is same. If you are asked investigation of choice in a child with recurrent UTI or investigation of choice in VUR, the answer to both these questions is similar. That is, the answer will be micturating cystourethrogram, or it can be voiding cystourethrogram. So it is MCUG or VCUG, right? What happens in micturating cystourethrogram? So you take serial pictures when the child is urinating, right? So you understand that where is the defect. Usually, other than that, we can go for radionuclide studies as well, which provides less radiation. But the investigation of choice, if you're asked, the answer will be micturating cystourethrogram. So this is the grading in vesico-ureteric reflux, right? So we, as you can see, we have got 5 gradings. Now just look at the ureter from 1 to 5. I think you can appreciate that in grade 1 and grade 2, we are having non-dilated ureter, right? So in grade 1 and 2 we are having non-dilated ureter, whereas in grade 3, 4 and 5, as the picture suggests, we are having dilated ureter. So grade 3, 4 and 5 is high risk VUR. Whereas grade 1 and 2 is low risk VUR. Differentiating into low risk VUR and high risk VUR is very important because it also helps us in management. So now see grade 4 and grade 5. So grade 5, I think you can appreciate the tortuous nature, right? So apart from being a dilated ureter, we are having what? We are having tortuous ureter. Have you noticed the tortuous ureter? And also there is loss of papillary impressions. Loss of papillary impressions. So if in the question it is asked that dilated and tortuous ureter with loss of papillary impressions, that means I am dealing with grade 5 VUR. So tortuous plus dilated ureter plus loss of papillary impressions. So tortuous plus dilated ureter plus loss of papillary impressions is what makes grade 5 VUR, and this is the most high grade VUR. Now come to grade 4. You already know it is a dilated ureter, but you are not finding any tortuosity, right? But there is blunting of the pelvic-calycial system. So the pelvic-calycial system is blunted. So apart from being it's a dilated ureter, we are also going to have blunting of the calycial system, both the major and the minor calyces. Now come to grade 1 and 2. In both the cases we have non-dilated ureter. It is vesico-ureteric reflux. That means reflux of urine occurs from the vesico, that is the bladder, to the ureter. So see in the grade 1, the reflux is still the lower part of the ureter. Okay, so that is grade 1. If the reflux is still the upper part of the ureter and also the calycial system, but it is not blunted and it is a non-dilated ureter, that means it is a grade 2. Grade 3, the ureter is dilated and the pelvic calycial system is also involved, but there is no blunting of calycial system. So have you understood the 5 grades of VUR? Now let me tell you, if you are asked what is the management of vesico-ureteric reflux, the answer will be continuous antibiotic prophylaxis. So what will be my answer? The answer will be continuous antibiotic prophylaxis. Okay, so continuous antibiotic prophylaxis. We need to know the duration of CAP. So CAP duration we need to know. For low risk VUR, that is grade 1 and 2, we are going to give it for up to 1 year of age. So for low risk VUR, and now you know what is low risk VUR, that is grade 1 and 2, we need to give it for up to 1 year of age. And anytime if the child is having any breakthrough UTI, suppose the child was, you gave the prophylaxis up to 1 year of age and then the child presents with a breakthrough febrile UTI. The child had a UTI and the child was febrile, breakthrough. Then you need to restart the prophylaxis. In a high risk VUR, that is grade 3 and onwards, you need to give it up to 5 years of age. And if it is a high risk VUR plus bowel and bladder dysfunction, so high risk VUR plus bowel and bladder dysfunction, in short we say BBD, then we need to give beyond 5 years of age. Now let me make you understand that whenever we are getting this vesicoureteric reflux, that is continuous reflux is happening from the urinary bladder to the kidney, right, to the calyceal system of the kidney, and if this is occurring repeatedly, then there is a chance of pyelonephritis, there is a chance of hypertension, there is a chance of renal dysplasia and scarring. Okay, so if you are having some risk factors, it will aggravate the process. Like in one question of INICET, there was one option, the chance of recurrent UTI increases in uncircumscribed males, and it increases the chance of vesicoureteric reflux. So it is a true statement. So in males who has not undergone circumcision, the chance of recurrent UTI increases, and in a way it increases the vesicoureteric reflux. And if the child is having bowel and bladder dysfunction, that is constipation, then there is also a chance of increased chance of vesicoureteric reflux. So that is why whenever we are getting a child or evaluating a child with recurrent UTI, we should always take the history of bowel and bladder dysfunction. This is very, very important. Okay, so because we need to put the child on stool softeners, laxatives, or some osmotic agents, and we need to monitor the bowel habits, because the chance of VUR increases, and we need to increase the prophylaxis beyond 5 years of age. Suppose it's a high risk VUR, and along with that bowel bladder dysfunction, and you're giving the prophylaxis, right? And anytime if you're having a breakthrough febrile UTI, that is an indication for surgery. Okay, so the indication of surgery definitely is failure of medical treatment, or it can be a parental concern. That is also if there is a deranged renal function, or if it is a failure of treatment. By what do you mean by failure of treatment? It's a breakthrough febrile UTI in case of high risk VUR, or breakthrough febrile UTI in a case of high risk VUR associated with bowel bladder dysfunction or any risk factors. Okay, so this summarizes the chart of vesicoureteric reflux. So let me tell you the one-liners one more. Most common cause of recurrent UTI, the answer will be VUR. Investigation of choice of recurrent UTI, the answer will be micturating cystourethrogram or voiding cystourethrogram, right? Next is, what is the treatment of choice in case of VUR? The answer will be not surgery. Remember, it is not surgery. Continuous antibiotic prophylaxis. If you are told that failure of medical management, breakthrough febrile UTI in high risk VUR, then we need to say it's a surgery ureteric reimplantation. What is the highest grade of VUR? That is grade 5, where we need to consider surgery, ureteric reimplantation. Rest grade 1 and 2 are the low risk, where we continue the CAP up to 1 year of age. In the high risk grade 3, 4, we need to give it for up to 5 years of age. And if it is with constipation, bowel bladder dysfunction, we need to give it beyond 5 years of age, right? So that summarizes the entire thing of vesicoureteric reflux. And another thing that you can remember, just I told you that if the child is having a unilateral renal agenesis, it increases the chance of VUR. Like in 15% cases, we can have VUR. The same thing in case of pelviureteric junction also. Pelviureteric junction obstruction, there is a 15% chance of having VUR. However, in posterior urethral valve, there is a chance of having VUR 50%. So if it's a male baby with oligohydramnios with a USG showing keyhole sign, there is a 50% risk of having VUR. You need to remember this figure, 50% in case of posterior urethral valve. So we already discussed some of the one-liners here. Most common cause of UTI, you all know, it's E. coli, right? And we know that the sterile method of collection of urine is suprapubic catheterization. So whenever you go for suprapubic catheterization, if you get any one organism, that is enough to call that it is UTI. But if you are going to go for a catheter, So if you're taking the sample from a catheter bag, it's more than 10 power 4, more than 5 into 10 power 4 organisms. If you're getting that, that is to be called as UTI. And suppose normally in wards, what do? We usually do not go for taking a sample from a catheterized sample or a suprapubic cystostomy. What we usually go is to collect the routine urine for routine examination. We advise morning, midstream, clean catch sample of urine, and in that if you're getting more than 10 power 5 organisms, that is significant. Okay, so normally the way we collect urine, it is not the best method, but it is the most commonly used method. That is the morning, early morning, midstream, clean catch urine for urine routine examination and microscopic examination, that you need to get more than 10 power 5 organisms to call as significant. If it is a catheterized sample, in suppose in unconscious patients or in intensive care patients, it is more than 10 power 4, and in suprapubic puncture, it is the most sterile method of collection of urine, and if you get a single organism also, that is enough to call it as UTI. So most common cause of recurrent UTI in children, the answer I already told, it is vesicoureteric reflux. Now another definition, what is meant by frequent febrile UTI. So UTI associated with febrile and frequent. So UTI where we have fever, so we need to know how much frequent it is. It is more than 3 episodes in 1 year. Most common mode of infection in UTI is ascending. I think you all know that urinary tract infections are more common in females as compared to males because there is an ascending route of infection rather than hematogenous, because ascending route is more common, and also the females are having a short urethra. However, if you're asked most common predilection in case of neonates, the answer will be male. Okay, so in neonates it's male. However, because in adults or in adolescents or in children, the answer will be female. So what is meant by the term complicated UTI? So here we are mainly seeing the definitions in case of urinary tract infection. So complicated UTI is, of course, you are having an UTI plus, of course, there is a fever. Fever more than 39 degrees Celsius, that is a high grade fever. Signs and symptoms of systemic toxicity like lethargy, poor feeding, scleroderma, etc. So signs and symptoms of systemic toxicity: loin pain or tenderness, renal angle tenderness, deranged KFT, serum creatinine. So deranged serum creatinine. So fever, high grade fever, systemic signs and symptoms, renal angle tenderness, and deranged KFT. So if in this cases, we will call it as complicated UTI. So in the next pattern, you can be just having a clinical scenario like a child presents with following investigations in the urine REME report, which is suggestive of 10 pus cells and 5 epithelial cells with no blood and protein. The child is also having high grade fever and deranged and serum creatinine 3.2. So what is the diagnosis? The answer will be not simple febrile UTI, it is complicated UTI. Okay, so remember this term, complicated UTI. Of course, in any suspected case of UTI, we go for urine analysis, urine REME, and culture sensitivity, right? And we start the patient on antibiotics. How we are going to follow up? Now, follow-up criteria in UTI is very much age specific, okay? So, age less than 1 year, age 1 to 5 years, and age more than 5 years. So, first let's concentrate on age less than 1 year. So, in age less than 1 year, we need to see three things: ultrasound kidney urinary bladder, micturating cystourethrogram. Why? Because we need to rule out vesicuratic reflux. And DMSA, remember S for S, that is, it is for renal scarring. Whenever you do an ultrasound, you mainly see the structure of the kidneys, right? Whether the kidneys are enlarged, whether the kidneys are small and contractile, what is the echo texture of the kidney, the renal parenchyma, appearance and thickness, the condition of the ureter, the bladder wall, thickness. This is what we see from USG kidney urinary bladder. Micturating cystourethrogram tells you whether I'm having a reflux or not. And what does DMSA tells you? Remember DMSA S, just remember this word S. So DMSA tells you whether there is a renal scarring, and it is a static scan. What is a dynamic scan? DTPA is a dynamic scan. So DMSA is a static scan. It will not tell you about the function of the kidney. It will tell you whether the kidneys are scarred. So remember this. So what is the investigation that will help you to understand renal scarring? The answer will be DMSA scan. Now, age 1 to 5 years, we'll have ultrasound USG. Next, it is DMSA. And if any of the above is abnormal, suppose we are going for USG KOB and DMSA, if either of these two is abnormal, then only MCU is done. So MCU is never done a routine. So age less than 1 year, we do all the three. Age 1 to 5 years, we do 2 investigations, and then we can do a third investigation. What about in age more than 5 years? It's only ultrasound. If it is abnormal, then we go for DMSA followed by MCU. So it is USG followed by DMSA, followed by MCU. So in INICET 2021, this sequence was asked, like age more than 5 years, what should be the order of investigations that you will order in a follow-up case of UTI? So it is first ultrasound kidney urinary bladder, then DMSA, and last is MCU. Remember, M is always last. So in wherever in age 1 to 5 years also, you first see whether there is any problem with the ultrasound kidney urinary bladder and DMSA, and then you go for MCU. Likewise, in age more than 5 years also, it is first USG, then DMSA, then MCU. Okay. So this is very, very important slide, and you should not miss this. Okay. Now this is an extra age thing, so you will only need it for INICET exams and not for the routine exams. Like a child with post-streptococcal glomerulonephritis. Okay, so when we are going to go for renal biopsy in a case of post-streptococcal glomerulonephritis, so we know, like in nephrotic syndrome, we already know, right? When we go for renal biopsy, extremes of age less than 1 year or age more than 10 years, and if the child is having steroid resistant nephrotic syndrome, or if we are starting calcineurin inhibitors in the child and prolonged treatment with calcineurin inhibitors, in all these cases we go for renal biopsy. Basically, what happens in nephrotic syndrome? In majority of the cases, we know what is going to be the histology, that is steroid sensitive, minimal change nephrotic syndrome. Only in some cases where we are having a doubt about other histologies, then we go for renal biopsy. And that is possible in extremes of age, congenital nephrotic syndrome, steroid resistant nephrotic syndrome, or effect of some drugs. Like in post-streptococcal glomerulonephritis, we know it is a disorder where we only go for conservative treatment. So in that case, when we go for renal biopsy, we need to remember the first point you see, it's oliguria, hypertension, and or azotemia, that is deranged renal function, if it persists for 7 to 10 days. So for 10 days, if you're having a child with oliguria, hypertension, and or azotemia, we have to order a renal biopsy. Gross hematuria, if it persists for 4 weeks. So if the child comes to you with a gross hematuria for 1 month, you are not going to wait and watch, you are going to plan a renal biopsy. Nephrotic range proteinuria persisting for 2 weeks Again, that is an indication for renal biopsy. And low C3 level, low complement C3 level persisting for 12 weeks, and proteinuria persisting for 6 months, and microscopic hematuria persisting for 12 to 18 months. Now let me tell you one scenario. You know what happens in post-streptococcal glomerulonephritis? We always send samples for ASO, anti-DNSB, C3 and C4. And we know we are going to have a low C3 level in case of PSGN. And this low C3 level is transient, because this low C3 level is going to reverse, or it is going to normalize in 8 weeks time. Again, this is a very important one-liner which I am going to discuss in my future slides. That is, the complement level normalizes in PSGN. When does it normalize? 8 weeks. If it doesn't normalize, if it persists for 12 weeks, you need to go for renal biopsy, because one of the reasons of having a persistently low complement level is lupus nephritis. Okay, there are other causes also, but at least for your level you need to remember we can have endocarditis, shunt nephritis, all this presence with transiently low complement level. But for your level, you just remember in PSGN we have low C3. This normalizes in 8 weeks. Much repeated MCQ. A child presents with cola colored urine, oliguria, hypertension, and you document low C3, normal C4 along with elevated anti-DNSB. When are you going to send a repeat C3, or when are you anticipating C3 going to normalize? The answer will be 8 weeks. But if you are asked this question, when will you plan a renal biopsy in a case of PSGN based on low complement level, the answer is going to be 12 weeks. Okay, so this is one of the very important question. Now second, look at it. Nephrotic range proteinuria, the duration is 2 weeks. Whereas persistent proteinuria is 6 months. So please look at the question whether it is asking you nephrotic range proteinuria or proteinuria. If it is nephrotic range proteinuria, it is 2 weeks. But if it is proteinuria, it is 6 months. So there is a difference between 2 weeks and 6 months. And microscopic hematuria is almost 1 to 1.5 years, 12 to 18 months, whereas gross hematuria is 1 month. So again, I am repeating this for your clarity. Gross hematuria, gross, 1 month. Microscopic, 1 year. Nephrotic range proteinuria, 14 days. Persistent proteinuria, 6 months. Complement level normalizes 8 weeks. Low complement level, which renders you to do a renal biopsy, that is 12 weeks. Okay. So you should mug up this slide, and this is the last moment revision for you. Now we are going to see some tubulopathies. And again, these tubulopathies are very, very important for your exams. So we are going to see the Bartter syndrome, the Gitelman syndrome, and the Liddle syndrome. Remember, Liddle syndrome is autosomal dominant. In all the cases, we are going to get hypokalemic metabolic alkalosis. So hypokalemia, metabolic alkalosis. In Gitelman, we are also going to get hypomagnesemia. How can you remember this? Remember, in Gitelman we have M, and here also we are having M. So M for M, right? So Liddle syndrome is basically gain of function mutation of ENaC channel. So what is ENaC channel? Is epithelium sodium channel. So gain of function mutation of ENaC channel. So it's a gain of mutation. So you're going to get hypertension. So tubulopathy presenting with hypertension, we have got two tubulopathies. One is Gordon syndrome and the number 2 is Liddle syndrome. Why you need to remember? So if you see in the questions, it's hypokalemia, metabolic alkalosis with hypertension, tubulopathy. The answer will be Liddle syndrome. and it is associated with ENaC channel and autosomal dominant. So you need to remember only these 3 points regarding Liddle syndrome. Now coming to Gentleman syndrome, it behaves like thiazide diuretics. And we know the site of action of thiazide diuretics is distal convoluted tubule, right? So the site of action of thiazide is distal convoluted tubule. And it acts on which transporter? Sodium chloride transporter in the early part of DCT. So Gentleman syndrome is a loss of function of sodium chloride transporter in the early part of DCT. And so if, Gentleman syndrome is a tubulopathy which results in loss of function of sodium chloride transporter in the early part of DCT. What is thiazides? They are diuretics which block this transporter. So whatever will be the mechanism of action of thiazide diuretics, the same thing is going to present in Gentleman syndrome as well. Okay. But remember, Gentleman syndrome usually you get in children, right? Not in early infancy or neonates. However, Bartter syndrome, the most important amongst all these three, you are going to get a neonatal presentation and a classical presentation. So Bartter syndrome has an early presentation. This is what you need to remember. Again, we have hypokalemic metabolic alkalosis. Bartter syndrome behaves like loop diuretics. So you all know one loop diuretic very well, that is the furosemide, right? Which we give for pulmonary edema, for hypertension, etc. So Bartter behaves like loop diuretics, and loop diuretics block which channel mainly? 1 sodium, 1 potassium, 2 chloride channel. This is the channel which is blocked by loop diuretics. So we'll have hypokalemic, hypochloremic metabolic alkalosis, and you should remember one mnemonic, that is loop loses calcium. So what you're going to remember the mnemonic? Remember this mnemonic. Loop, that is loop diuretic, loses calcium. Okay. So if the loop loses calcium, where it is going to lose? It is going to lose it in the kidney, in the urine. So we are going to have hypercalciuria and nephrocalcinosis. See, nephrocalcinosis is a very important topic. So nephrocalcinosis, that is renal stones. So which tubulopathy results in renal stones? The answer will be Bartter syndrome. Now next I'll teach you about the renal tubular acidosis. If I ask you which RTA presents with nephrocalcinosis, the answer will be RTA type 1. One anti-HIV drug which presents with nephrocalcinosis, the answer will be indinavir. Okay. And also remember, whenever there is a hypercalcemia, there is a chance of precipitation of nephrocalcinosis. So whenever there is a calcium excretion more than 4 milligram per kg per day, okay, there is a chance of nephrocalcinosis. Now we have got various subtypes of Bartter. You may not know everything, but at least few you should know. Bartter syndrome type 1 is basically a defect of one sodium, 1 potassium and 2 chloride channel. Now type 2 is a defect of Fmge. It is a potassium channel defect. Whereas type 3, it is a chloride channel defect in the basolateral membrane. Type 4, it's chloride channel defect along with a protein defect, accessory protein associated with chloride channel. It is actually, we say CLC-Ka and Kb. You can remember it, an accessory protein of chloride channel. And type 5 is associated with three mutation. So even if you forget everything, at least you remember type 3 is classic. and type 4 is associated with sensory neural hearing loss. And Bartter syndrome is autosomal recessive excepting type 5, which is X-linked. So, NEETPG question: the most common channel defect in Bartter syndrome, 1 sodium, 1 potassium, 2 chloride channel defect. Type of Bartter syndrome associated with sensory neural hearing loss, it is type 4. Hypokalemic metabolic alkalosis with hypercalciuria found in which tubulopathy? It's Bartter syndrome. Nephrocalcinosis found in which tubulopathy? Bartter syndrome. Hypertension found in which tubulopathy? Liddle syndrome. So these are the one-liners that you can expect from the inherited tubulopathies. So of course, management, you understand that in case of Bartter and Gentleman, we need to go for potassium supplementation, right? Along with that, we need to go for sodium supplementation as well. And in case of Liddle syndrome, there is a hypertension, so we need to manage that. And potassium supplementation is also required. Now coming to the renal tubular acidosis. Now before I talk about this chart of renal tubular acidosis, let me tell you. Now normal pH is 7.35 to 7.45. I will discuss this in my last general pediatric section a bit. So if the pH is less than 7.35, we call it as acidosis, right? So whenever we are seeing this acidosis, next we look at the bicarb level. If the bicarb level is low, so bicarbonate level is low, then it is a metabolic acidosis. So the pH and the bicarbonate, if that goes in the same direction, that means it's a primary metabolic disorder. Understood? So primary metabolic disorder if the pH and the bicarbonate goes in the same direction. Now, if you see the pH is going down and PCO2 is going up, or the pH is going up and PCO2 is going down. So pH and the PCO2, if they are behaving in an opposite direction, that means it's a primary respiratory disorder. So whatever compensation will occur, be it in a metabolic case or in a primary respiratory case, always the compensation will be in the same line to that of the primary disorder. For example, if the pH goes down, that is acidosis. Bicarbonate going down, that is metabolic acidosis. If the PCO2 is going down, that means it's a compensated metabolic acidosis. So if I say pH going up, that means alkalosis. Bicarbonate going up, that means metabolic alkalosis. If the PCO2 going up in response to this, that means it's a compensated metabolic alkalosis. If the pH going down, that means acidosis. PCO2 going up, that means it's a respiratory acidosis. Bicarbonate going up, that means it's a compensated respiratory acidosis. So hopefully you understood this. So whenever we are seeing a case of metabolic acidosis, we need to see what about the anion gap, plasma anion gap. So plasma anion gap is a measure of unmeasured anions minus the unmeasured cations. Unmeasured anions minus the unmeasured cations. Okay. So I have already taught this in my regular classes. I will take a class also discussing some of the ABGs. But for now on, you just remember that plasma anion gap is equals to unmeasured anions minus unmeasured cations. And the formula is sodium minus chloride plus bicarbonate. We do not have potassium over here, and the normal value is 8 to 12 millimeters of mercury. So if the plasma anion gap is 8 to 12, okay, so if this gap comes out to be 8 to 12, it was a slip of tongue, it's millimoles, okay. So sodium minus chloride plus bicarb, if it is 8 to 12, right? If it is, then we call it as normal anion gap metabolic acidosis. Normal anion gap metabolic acidosis. If it is more than 12, we call it high anion gap metabolic acidosis. So renal tubular acidosis falls in normal anion gap metabolic acidosis. So whenever we get a normal anion gap metabolic acidosis, we usually calculate the urinary anion gap. So what is the urinary anion gap? Can anybody tell what is the urinary anion gap? The formula is sodium plus potassium minus chloride. So here we have the potassium, sodium plus potassium minus chloride. Now this gap can come out to be positive or negative. Remember, if it is coming out to be negative, in negative we have a G. That means it's a GI problem, pancreatic diarrhea. If it is a positive, that means renal tubular acidosis. So at least you remember that renal tubular acidosis is one condition where there is a problem with the tubules of the kidney. So problem with the renal tubules, acidosis, that means there is a metabolic acidosis. And of course, in any metabolic acidosis, we need to see what is the plasma anion gap. So it is a normal anion gap metabolic acidosis, and along with that the urinary anion gap is positive. So see this point, urinary net charge. So let me tell you these three columns. The first one is type 1 RTA. The next is the type 2 RTA. And the last one is the type 4 RTA. Okay, so in this 1, 2 and 4, so we have got 4 types of RTA, 1, 2, 3 and 4. I have skipped type 3 because it is extra age, a bit of the residents should know, not in NEETPG. So type 1, 2 and 4. Okay, so in all these 3 are the types of renal tubular acidosis, which are normal anion gap metabolic acidosis. The plasma anion gap is, that is sodium minus chloride plus bicarbonate, ranges between 8 to 12, and the urinary net charge is positive in all the 3. That means the urinary anion gap is positive in all the 3, right? So there is some controversy regarding the type 2 and the urinary net charge. So we are not going to read it here. You can refer to my videos in the GAMEPGAPP app, where you can have a detailed discussion on RTA, or I'll take a separate YouTube session on the renal tubular acidosis and their manifestations. Just see type 1, 2 and 4. In serum potassium in type 1 and 2 is low. So potassium in 1 and 2 is low. So before and in type 4 it is high. Remember, type 1 is a distal RTA. There is a problem with the H plus secretion. Type 4, there is a problem of aldosterone deficiency or resistance. So type 4 is also a distal RTA, whereas type 2 is a proximal RTA. The first thing you need to remember, type 2 is proximal RTA, type 1 and 4 is distal RTA. Okay. So if it is a proximal RTA, that means the distal acidification is intact. There is no problem with the distal acidification. That means the urinary pH, that is the pH, okay, pH, in the presence of acidosis is going to be normal, that is less than 5.5 in case of type 2, because the distal acidification system is normal, is okay, intact, whereas type 1 it is more than 5.5. So urinary pH is deranged or more than 5.5 in type 1, whereas it is normal in type 2. Okay. Next, you remember the fractional bicarb excretion, again, which is going to be more affected, type 2, because the proximal one only deals with the bicarb re-acclimation, right? So fractional bicarbonate excretion 10 to 15% in case of type 2, whereas in 1 and 4 it is not such. So fractional bicarbonate excretion is maximum in type 2, followed by type 4, followed by type 1. So Fanconi syndrome, again, problem with the proximal tubules. So it's with type 2. And serum potassium is high only in type 4. Response to therapy is poor in type 2. So proximal and poor goes hand in hand. So poor in type 2. If there is nephrocalcinosis, that is stones, that means it is associated with type 1. And already I told about the Fanconi syndrome. So since this is a revision class where we are going for a marathon of all the things, so a very brief overview. Nephrocalcinosis in which RTA type 1. You can remember stone, stone, S-T-O-N-E. So stone has the letter 1. So type 1 nephrocalcinosis. Fanconi syndrome type 2. It is not Fanconi anemia. Fanconi anemia is something else. It is Fanconi syndrome. So Fanconi syndrome in type 2 RTA. Okay. Type 2 RTA, the prognosis is poor. Fractional bicarbonate excretion maximum in type 2. Hypokalemia in type 1 and 2. So which RTA presents with hyperkalemia? Type 4. And what is the most common type of RTA in adolescence or overall? It is type 4. So most common type of RTA is type 4. Okay. So these are the one-liners which you need to remember from renal tubular acidosis, right? Next we are going to start about the nephrotic syndrome. Next we are going to do nephrotic syndrome. Now nephrotic syndrome, usually the presentation is going to be anasarca or generalized body swelling. Along with that, there is going to be decreased albumin level. Along with that, there is going to be nephrotic range proteinuria. Remember, hyperlipidemia more than 200 is definitely found in nephrotic syndrome, but it is not a criteria anymore after the recent change in the guidelines in nephrotic syndrome. So anasarca, you understand that it's a generalized body swelling, decreased albumin levels. And what do we mean by nephrotic range proteinuria? See over here, urinary protein excretion more than 40 milligram, very important number, more than 40 milligram per meter square per hour. If we have to say per day, it is more than 1 gram. Urine dipstick, the urine protein is 3 plus to 4 plus. Whenever we are having a urine dipstick of 4 plus, that accounts for more than 1000 almost, right? And the first morning urine sample, we are going to calculate the urine PCR or the urine albumin creatinine ratio, that is more than 2:1. So what is the normal value? It is less than 0.2. From 0.2 to 2, it is nephritic range. And if it is more than 2, that means it is nephrotic range proteinuria, right? Another thing, sometimes we get urine dipstick is negative, and whenever we do the cumbersome 24-hour urinary protein estimation, we find that it is elevated. So this discrepancy, if we are getting somewhere in the reports where the urine dipstick negative and 24-hour urinary protein is more, that means we are dealing with something which is known as overflow proteinuria, and that is found in multiple myeloma where there is excretion of light chains, and that is not detected in the urine dipstick. So one MCQ, if you are having a question like this, that in the urine dipstick it's negative, 24-hour urinary protein is positive for proteins, that means there is excess excretion of light chains, that is suggestive of multiple myeloma or overflow proteinuria. What is the most common cause of proteinuria? Right? It is transient proteinuria or orthostatic proteinuria. Most common cause of nephrotic range proteinuria, definitely it is nephrotic syndrome. And another thing that you can remember is that the most common cause of oliguria in children is definitely dehydration, right? It is not nephrotic syndrome. In nephrotic syndrome, you will get edema, you will get oliguria, and mostly the mothers will come and say that there is periorbital edema. They noticed in the morning hours, there is periorbital edema. Usually the teaching goes in the undergraduate days is the sequence of edema. If we find the edema starting from the face, it is always kidney. If we see the edema starting from the legs, lower legs, it is cardiac, right? And it is from the abdomen, then it's a GI cause. So we need to understand the cause of edema. So if you'll be given this triad and also the investigation reports of albumin and the urine analysis. In nephrotic syndrome, usually we get hyaline casts, or lipid casts can also be seen. So this number is very important, and this number is also very important. And all this thing, that is urine dipstick, urine heat test, all this tests in nephrotic syndrome, you need to repeat it for 3 consecutive days. This also is very important. A single test will not do. You need to repeat it for 3 consecutive days. Now, suppose already I told one scenario where the child presented with oliguria, anasarca, and there was low albumin levels with increased proteinuria. That is nephrotic syndrome. Suppose a child presents to you with cola colored urine. Or what we call as hematuria. And there is also associated hypertension. Usually you do not get hypertension in nephrotic syndrome. If you are finding hypertension in nephrotic syndrome, either it is atypical, it is a nephritic nephrotic syndrome, you are doing the wrong diagnosis, or it is extremes of age. That's why you are getting hypertension. Or there can be azotemia, deranged renal function. That is also less in case of nephrotic syndrome. And there is hematuria. So hematuria, hypertension, azotemia, this is what the presentation of the child is like, and you inquire, and there is also a history of sore throat or pharyngitis. Now what you are going to do? You ask about the history. That is whether there was the sore throat was 1 to 3 days prior to the onset of hematuria, or it is weeks prior. So if it is 1 to 3 days prior, then you are dealing with a disease which is known as IgA nephropathy or Berger's disease. You should remember IgA nephropathy is the most common cause of glomerular disease in the world, right? And it is the most common cause of gross hematuria, as well as it is the most common cause of microscopic hematuria. So in IgA nephropathy, the prognosis is usually very good. If there is hypertension or deranged renal function, then only we need to go for steroids and others. Otherwise, it's a conservative fluid and rest management. And remember, fish oil is indicated. Fish oil has omega-3 fatty acids. So fish oil is indicated in which renal disease? The answer will be IgA nephropathy. So in IgA nephropathy, usually if we go for a renal biopsy, we'll find IgA deposits in the mesenterium. One question, do we go for measuring the serum IgA levels? The answer is no, because serum IgA levels are elevated only in 15% of cases. So we do not go for measuring the serum IgA levels. We are only interested for conservative management, seeing the complication, measuring the BP, seeing the urine output of the patient, and the generalized volume status of the patient. So since this hematuria occurs 1 to 3 days prior this pharyngitis, it is known as synpharyngitic hematuria. So what is it called? Synpharyngitic hematuria. Okay. Now another presentation, either it is 1 to 3 weeks prior. Now another child came to you with the same symptoms, but she says that I did not have sore throat, but I had a skin infection, pyoderma, and the period is almost 4 to 6 weeks prior. There was a skin infection. So then you are dealing with the most common cause of acute glomerulonephritis, that is nothing but post-streptococcal glomerulonephritis. So this is what we call as delayed hematuria. So delayed hematuria, the answer will be PSGN. If it is a synpharyngitic hematuria, the answer will be IgA nephropathy. If it is a skin infection, the latent time will be more. If it is a pharyngitis, the latent time will be shortened. And it is the most common cause of acute glomerulonephritis will be PSGN. Most common cause of glomerular disease in the world will be IgA nephropathy. Most common cause of gross and microscopic hematuria will again be IgA nephropathy. So you can get a scenario based question, and you need to mark IgA nephropathy and PSGN very carefully. Now some one-liners regarding post-streptococcal glomerulonephritis. Now do you know, if you do a microscopic examination of in post-streptococcal glomerulonephritis, right, you get electron dense deposits. They are known as lumpy, bumpy deposits which exhibit a starry sky pattern. So in electron microscopy, in PSGN, we are going to get lumpy, bumpy deposits, or what is called as starry sky pattern. Can you tell me one hematological manifestation where you get the starry sky appearance? That is Burkitt's lymphoma. So starry sky pattern in a renal biopsy is PSGN. It's also known as lumpy bumpy deposits, right? And PSGN can progress to RPGN. So in PSGN, usually the management is conservative. But what we advise our residents to do, that is measure the BP every morning and evening. So because there is a chance of hypertensive encephalopathy. We also advise there is a chance of posterior reversible encephalopathy syndrome or the PRES syndrome. And there can be effects on heart as well. So there can be complications from PSGN, and PSGN can lead to RPGN as well, rapidly progressive glomerulonephritis. So what you need to monitor in PSGN is the complications, right? Otherwise you need to go for a conservative treatment. So PSGN is basically because of group A beta hemolytic streptococcus, the same as that of acute rheumatic fever, but in acute rheumatic fever we have the rheumatogenic strains, whereas in PSGN we have the nephrogenic strains. Okay, so what are the nephrogenic strains? We have 1, 4, 25, 49. Remember one thing that is usually asked, that is 49, that is after pyoderma or skin infection, right? This was in Fmge 2018, this was asked, that after a child presents with cola colored urine and hypertension, and there was a history of skin infection 6 weeks prior. So, which strain is responsible for this disease? The answer will be nephrogenic strain 49 of group A beta hemolytic streptococcus. Now, this SPEB is a very sensitive protein which is found in PSGN again. It's a sensitive protein. Now, next, already I told you that in PSGN you get hematuria, you get hypertension. And in PSGN, we sent titers for ASO, anti-streptolysin O, anti-DNS, serum C3, serum C4. Usually serum C3 is low. And among ASO and anti-DNS, which one is more sensitive? The answer will be anti-DNS. So anti-DNS is more sensitive investigation as compared to ASO. So if you have to choose that which is better, anti-DNS is better than ASO. So this is a mnemonic 2, 4, 6 and 8 and all in weeks. 2 weeks, 4 weeks, 6 weeks and 8 weeks. I usually tell my students and my residents that please remember like this. First is 2 symptoms, hematuria, hypertension. Then 2 investigations, anti-DNS, serum C3, right? So serum C3 already you know as a one-liner that serum 3 normalizes. This is when do these symptoms normalize in PSGN. You already know serum C3 normalizes in 8 weeks. So this is, you already know this, right? So you don't know when anti-DNS normalizes. So anti-DNS normalizes in 6 weeks. Hypertension normalizes or becomes normal in 4 weeks and hematuria disappears in 2 weeks time. So you remember 2, 4, 6 weeks, 2, 4, 6 and 8. You already know 8 is linked with serum C3. You need to remember only hematuria, hypertension, anti-DNS, right? Now, this is a direct, I took this screenshot from the guideline itself of steroid sensitive nephrotic syndrome. So we have got one flow chart regarding the clinical orientation in nephrotic syndrome and 2 charts regarding the definition in nephrotic syndrome. So I have already discussed this in my regular classes as well, and this is very, very important. So because every line is a potential MCQ. So let's do it, and we'll do it in a very brief manner and a very organized manner, so every one of you can understand this. So you know in nephrotic syndrome we have edema, right? So edema at disease onset or relapse. So if whenever you're getting an edema, what is the next step you need to do? Suppose a child presents with oliguria, edema, nephrotic range proteinuria, and you have diagnosed is as nephrotic syndrome, and you have started steroids for the patient. Next, you're assessing the volume status of the patient. So usually those of you who are not exposed to pediatrics may ask that how do you assess the volume status, right? So at least this is not actually for pediatrics, it's for any part of medicine, that how do you assess volume status in an individual. Like first is some symptoms, next signs, and some investigations. Usually if there is hypovolemia, you will find that there is nausea, vomiting, lethargy, abdominal pain. All the symptoms you're going to get. Signs, the pulse volume is going to be poor, there is going to be low blood pressure, low capillary refill time. So all this will point towards signs in case of nephrotic syndrome. And what about investigations? The hematocrit will be more, there is going to be hemo concentration, and you can also see uric acid, that is also going to be elevated. So this is how, or the PCV is going to be more. You assess hypovolemia in an individual, and in intensive care usually we see the IVC collapsibility index to judge the hypovolemia. So suppose you see in your question paper it's written that the pulse volume is poor, there is capillary refill time is delayed, low blood pressure, nausea, vomiting, lethargy, poor feeding, that means the volume status is low. So you have already initiated therapy with prednisolone. So if the volume status is low, then we look at this flowchart, that is a child with edema and nephrotic syndrome with low volume status or hypovolemia. So what to do next in a child with hypovolemia? So rather I can frame the question like this: a child presents with nephrotic syndrome, there is presence of edema along with low volume status, the child did not pass urine for the last 8 hours, what to do next? So this is a clinical oriented question and you must be very thorough, right? Remember one thing, if there is low volume status, the answer will be normal saline bolus. So IV normal saline is what you need to give. If the child is again having low BP, you can repeat the normal saline bolus 10 to 20 ml per kg over 30 minutes. And if that also doesn't help, then you can go for IV albumin. So first of all is NS bolus, then also it's NS bolus. You can give a repeat NS bolus. Next we go for the maintenance fluids, and albumin is not the first option. So even if you forget everything, this entire flowchart is main detailing you need for the residence or the INICET exams. For next pattern of questions, you should only remember a child with nephrotic syndrome with hypovolemia. What to do next? The answer is going to be normal saline bolus. Okay, now come to this part. Assess for hypovolemia and there is no hypovolemia. If there is, the volume status is normal, next we need to see the edema, whether it's a mild edema or moderate to severe edema. See, mild edema is 7% increase in body weight is what we call as mild edema. Then you just need to restrict dietary salt. Do not take dietary salts. This is going to be your advice. If it is a salt restricted diet, if it is a moderate to severe edema, that is 7 to 15% increase in the body weight. I think all of you know more than 7% increase in body weight. That in nephrotic syndrome, every day in the wards we need to measure the abdominal girth, the blood pressure, the body weight. It's always there is, we need to maintain the nephrotic chart. So already we have restricted the dietary salt. Along with, you need to give furosemide, that is loop diuretic, it's oral. So remember, the first thing that you need to go is oral Lasix, oral furosemide. You can add spironolactone because it's a if you are going to give furosemide for a long period of time, so there can be chance of you need to spare the potassium, right? So you need to add a potassium sparing agent. That's why you have to add spironolactone. So if you already restricted salt, you already added oral furosemide, but still you're having this edema and it is not responding, what you're going to do? Next you're going to add thiazide. So add metolazone or hydrochlorothiazide. So what thiazides you can prefer in case of nephrotic syndrome? The answer will be metolazone and hydrochlorothiazide. And you can also consider now IV furosemide. Previously it was a oral Lasix. Now you can give a IV furosemide, or you can give an infusion of furosemide as well. IV furosemide 1 to 2 milligram per kg. You can give bolus, and you can go for IV infusion of furosemide. If that also doesn't seem okay, next option is IV albumin. 0.5 20% albumin, 0.5 to 1 gram per kg over 4 hours, followed by Lasix. Why we give Lasix after albumin infusion? To prevent heart failure. And if it is refractory, the last stage is isolated ultrafiltration. Sorry. Okay. So what to do next? In case of moderate to severe edema, the first thing will be oral Lasix, followed by thiazide, followed by IV infusion of furosemide, followed by IV albumin. The last stage is ultrafiltration. So if the question is like what to do next, the answer will be just dietary salt restriction and oral furosemide. If the question is in a refractory case of edema, moderate to severe edema in a nephrotic syndrome which has not responded to diuretics as well as albumin, what is the last step? The last step is isolated ultrafiltration. In INICET, if you have to write the order, then it is furosemide followed by thiazides, followed by IV furosemide, followed by IV albumin, followed by ultrafiltration. Okay, so you need to remember these three tables. First edema, next assessing the volume status. If the volume status is low, the only one answer, normal saline bolus. If the volume status is normal, next you need to see if it's a mild edema, then it's only salt restriction, that is 7% increase in body weight. If it is more than 7% increase in body weight, it's salt restriction and oral furosemide. So these are the three MCQs which I discussed. You need to remember as a clinical pattern question for your exams. Next, the definition of disease course and severity in nephrotic syndrome. So first is the nephrotic range proteinuria. I already talked about this. That is the urine protein 3 plus or 4 plus, and the urine PCR is more than 2 milligram per milligram in the first morning urine sample, and the proteinuria is more than 40 milligram per meter square per hour. Coming to remission. What is meant by remission? It's a urine protein nil or trace, that is the UPOC less than 0.2. I already told you 0.2 from 0.2 to 2, it is nephritic range. So less than 0.2 means it's normal for 3 consecutive early morning specimens. And what is relapse? It is urine protein more than equal to 3 plus, or the PCR is more than 2 milligram per milligram for 3 consecutive early morning specimens in a child who was previously in remission. Now this too is very important, FRNS and SDNS. First is FRNS, that is frequently relapsing nephrotic syndrome. Please listen very carefully. 2 or more relapses in the first 6 months after stopping initial therapy, more than equal to 3 relapses in any 6 months, and more than equal to 4 relapses in 1 year. So how do you remember? You just remember 3 golden numbers, 2, 3 and 4. So 2, 3 and 4 is what you need to remember. So more than 2 relapse equal to more than equal to 2 relapse in the initial 6 months, in 6 months, but this is initial 6 months. More than equal to 3 relapse in any 6 months. So you have to read very carefully that whether in the question it is mentioned any 6 months or in the initial 6 months after stopping, and more than equal to 4 relapse in 1 year. Okay. So more than equal to 2 relapses in the initial 6 months, more than equal to 3 relapses in any 6 months, and more than equal to 4 relapses in 1 year. This is what we call as FRNS. Now coming to SDNS, it is 2 consecutive relapses when on alternate day steroids or within 14 days of discontinuation. We already know this, that whenever you stop the steroids, After 14 days, if the child is having a relapse, or if you're on alternate day steroids, if the child is having a relapse. But what we forget, that it is not one relapse, it is 2 consecutive relapse. Remember this, it's a 2 consecutive relapse. So you do mistake here only. So it's a 2 consecutive relapse when on alternate day steroids or within 14 days of discontinuation of steroids. And in FRNS, it is 2 or more relapses in the first 6 months after stopping initial therapy, more than equal to 3 relapses in any 6 months, or more than equal to 4 relapses in 1 year. Okay. Next, coming to the next set of definitions. SRNS, again very important. Now whenever I say SRNS, I always say I am telling the definitions in children, because you sometimes get confused with the adults, right? So SRNS, steroid resistant nephrotic syndrome, it's lack of complete remission despite therapy with daily prednisolone. Very important this term, daily prednisolone, at a dose of 2 mg per kg or 60 mg per meter square daily for 6 weeks. So this is a very repeated MCQ, that how long, and it underwent a recent change. So it's 6 weeks. Daily prednisolone 6 weeks. उसमें भी remission नहीं हो रहा है, तो steroid resistant nephrotic syndrome. So suppose you get a scenario that where a child is not going for remission for 6 weeks despite daily prednisolone at appropriate dosing. What to do next? Then the answer will be renal biopsy. So what to do next? The answer will be renal biopsy. What drug you will prefer? Answer will be calcineurin inhibitors. Calcineurin inhibitors. उसमें भी अगर चूज करना पड़ा तो tacrolimus over cyclosporin. Next, coming to complicated relapse. We have already done what is relapse, what is FRNS. Now complicated relapse, only 3 things, remember. All the complications of nephrotic syndrome इसमें नहीं है. So कौन सा complications है? Relapse associated with life-threatening complication. Number 1 is hypovolemia, which requires inpatient care. उस ऐसे hypovolemia हुआ कि admit करना पड़ा. So hypovolemia. Number 2 is severe infection, peritonitis, cellulitis, meningitis. So what is meant by severe infection? It is only peritonitis, cellulitis, meningitis, not pneumonia. So peritonitis, cellulitis, meningitis, PCM, peritonitis, cellulitis, meningitis, and P is not for pneumonia, P is peritonitis. And last is thrombosis. So what are the complications? Hypovolemia, severe infection, and thrombosis. Now significant steroid toxicity. First is hyperglycemia. Okay, so hyperglycemia usually we define as fasting more than 100 and postprandial more than 140, or HbA1c more than 5.7. Obesity. So body mass index more than 95th percentile, short stature, height less than 2 standard deviation for age, and raised intraocular pressure, cataract, myopathy, osteonecrosis, psychosis. Basically, whenever you are giving steroids in a child, I already told you in my first session on rheumatology, in steroids we need to be very careful because there is a growth failure, chance of growth failure, so short stature, and there are ocular manifestations like cataract, glaucoma, etc. So there can be myopathy, psychosis, raised IOP, and of course we need to go for a metabolic screen like of hyperglycemia, obesity. So this is what we need to go in management regarding a child on nephrotic syndrome on a prolonged period with steroids. So every time a nephrotic syndrome child comes to my OPD, I need to measure the height and the weight. So anthropometry is a must. We need to go for an ocular examination at least once a year, and we also need to see the body mass index, which is again included in anthropometry, and the capillary blood glucose levels to test for hyperglycemia, right? Now this is a new entity, that is difficult to treat steroid sensitive disease. You can get this definition in your INICET paper. So difficult to treat is both of the following. See, it is both, again important. FRNS or significant steroid toxicity with infrequent relapses, and it is not or, दोनों साथ में रहना है. Failure of more than equal to 2 steroid sparing agents. What are the steroid sparing agents that we use in nephrotic syndrome? Levamisole, cyclophosphamide, and mycophenolate mofetil. So either those steroid sparing दिया but काम नहीं हुआ, so failure of more than equal to 2 steroid sparing agents, or it's a FRNS or significant steroid toxicity with infrequent relapses. So this completes our definition with respect to nephrotic syndrome. So what is the management? So first, management of nephrotic syndrome. So first episode of nephrotic syndrome management. So you have already done or read in your undergraduate days. It's 2 milligram per kg oral prednisolone on daily basis for 6 weeks. So first episode is always 6 plus 6, you remember. So maximum we can give 60 milligram and 1.5 milligram per kg oral prednisolone on alternate day for 6 weeks, and maximum again you can give is 40 milligrams. Now you need to know the drug of choices. Again, this is very, very important. For steroid resistant nephrotic syndrome, I already told you that it is a daily therapy देना है, उसके बाद भी remission नहीं हुआ for 6 weeks. We call it as SRNS. What is the drug of choice in case of SRNS? The drug of choice in case of SRNS is calcineurin inhibitors. What is CNI? CNI stands for calcineurin inhibitors. Cyclosporin and tacrolimus. इसमें अगर एक चूज करना है एग्जाम में तो आंसर विल बी tacrolimus. Steroid dependent nephrotic syndrome, the answer can be oral cyclophosphamide, mycophenolate mofetil, rituximab. Usually, let me tell you what happens in steroid dependent nephrotic syndrome. On FRNS also, low dose steroids and levamisole. Levamisole is an immunomodulatory agent. It's an anti-helminthic drug. Usually what happens in FRNS, the child comes to me with frequent relapsing nephrotic syndrome. Usually we try to find out the steroid threshold. That is, at which dose of steroid we tapered the steroid dose. We were giving 1.5 milligram per kg oral prednisolone, so we taper it. We go for 1 milligram per kg, 0.9, 0.8, 0.7, 0.6, 0.5. We go in the range of 0.5 to 0.7 milligram per kg, this low dose steroids. And we try to find out at which threshold of steroid the child is having a relapse of nephrotic syndrome. If it is more than 1, and if it is a complicated nephrotic syndrome, complicated I already told you, having hypovolemia, PCM, that is peritonitis, cellulitis, meningitis, right, thrombosis, all these are complicated, and or having significant steroid toxicity, then usually we start the child with cyclophosphamide, rituximab or MMF. Only एक choose करना है तो cyclophosphamide. If the steroid threshold is less than 1, right, and the child is not having any complications or not having any steroid toxicity, usually we go for levamisole. So levamisole is usually given in low risk patients, whereas in case of high risk patients we prefer cyclophosphamide, mycophenolate mofetil or rituximab. Rituximab is anti-CD20, very important. It's a B cell depleter used in many conditions. So it's an anti-CD20, right? It's a B cell depleter. Another question you should remember, so whenever you know it's a steroid resistant nephrotic syndrome, we go for a renal biopsy and then we start cyclosporin tacrolimus. So why do we go for renal biopsy in steroid resistant nephrotic syndrome? Because in majority of the cases of steroid resistant nephrotic syndrome, usually we get FSGS as the histopathology and not MCNS. That is one. Number two, before starting steroid, in case of steroid resistant nephrotic syndrome, before starting with the calcineurin inhibitors, we need to see the renal architecture, because cyclosporin and tacrolimus both are nephrotoxic agents, and still we are giving in these conditions because they're immunomodulators, right? Because they're calcineurin inhibitors, so they can change the renal architecture. So before starting the child or the patient with these agents, we need to see a renal biopsy. Prolonged treatment with these conditions, like prolonged treatment for 30 to 36 months, almost 2 years, you remember, we need to repeat renal biopsy. So calcineurin inhibitors start करने के पहले steroid resistant nephrotic syndrome में we need to go for renal biopsy. On cyclosporin tacrolimus, if renal function deteriorates or if it's a prolonged treatment after 30 to 36 months, we need to repeat renal biopsy. Nephrotic syndrome is a very high yielding zone. So most common cause of nephrotic syndrome, we know it is idiopathic, right? It's a steroid sensitive nephrotic syndrome and it's an idiopathic. So most common histology is minimal change nephrotic syndrome. In minimal change nephrotic syndrome, remember, in light microscopy and immunofluorescence, we get no deposits. So nothing is visible in light microscopy and immunofluorescence, we get no deposits. Only in electron microscopy, we find effacement of food process of podocytes. Podocytes are the visceral epithelial cells. Okay, so only in electron microscopy it is visible. So that is why minimal change nephrotic syndrome is also known as nil disease, NIL, because there is no deposit. So if you're asked in question, a child's presence with oliguria, edema, nephrotic range proteinuria, and you go for a renal biopsy, what do you expect to see in the immunofluorescence? The answer will be no deposit. So most common histology in SRNS is going to be FSGS, focal segmental glomerulosclerosis. Okay, focal segmental glomerulosclerosis is what you can get in case of FSGS. And what is collapsing variant? Collapsing variant of FSGS is bad prognosis. Remember, tip variant of FSGS is associated with good prognosis. So collapsing variant you're going to get in HIV and parvovirus B19. Even if you forget parvovirus, you need to remember HIV, because most common renal finding in HIV, this is a very common question asked. The answer will be collapsing variant of FSGS. So focal segmental, that is only focal. If we consider the entire, suppose we have got 50 nephrons, among them 25 nephrons will be affected, so it's a focal. And also in this 25 nephrons, only a segment will be affected, so it's focal segmental. And again the glomerulus is affected, so focal segmental glomerulosclerosis is the pathology. So focal segmental glomerulosclerosis is what we are going to get, right? And remember, all this thing I am telling in case of children, this is not so in case of adults and elderly, because in elderly we'll have MGN to be the most common histology, membranous glomerulonephritis, and in adults we are going to get FSGS to be the most common histology. However, in children, and this nephrotic syndrome PSGN is a hot favorite of all the examiners in any exams you sit. Okay, so we have finished pediatric nephrology, and we are going to just rush through a bit of pediatric infectious diseases. So first question is neurocysticercosis. So we know that neurocysticercosis is a parasitic infection affecting the brain. It is because of neurocysticercosis results in focal seizures and raised intracranial pressure. So we'll have focal seizures, raised intracranial pressure. So we need to go for neurocysticercosis. We need to think about neurocysticercosis, and it will present. You know this very well because it presents as a ring enhancing lesion. So always in radiology you have a confusion that whether we are dealing with a tuberculoma or we are dealing with an NCC. Usually you can read this from your radiology faculties, that how to differentiate between tuberculoma and NCC. Just let me tell you in a very brief manner. If there is any mass effect, if there is midline shift, if it is a great edema or great perilesional edema, if the size is more, then it is tuberculoma. So if there is no mass effect, no midline shift, no less edema, less size, the borders are regular, and there is, you can see a live scolex, that means you are dealing with neurocysticercosis. So mainly we need to know the treatment of neurocysticercosis. Parasitic infection, तो anti-helminthic तो देना, anti-parasitic agent तो देना ही है. That is, we need to give albendazole. But albendazole we need to start from day 3 of the illness. From day 1 of the illness, we need to start with steroids, either prednisolone or dexamethasone, right? And remember, you can give anti-parasitic agents and after you have ruled out. So always ruling out is very important. What you need to rule out: ocular cysticercosis. So how can you rule out ocular cysticercosis? You need to go for a slit lamp examination and ultrasound, B scan. Okay. And you need to rule out spinal cysticercosis. For ruling out spinal cysticercosis, you need to go for a neuroimaging, and it is not calcified because there is no point giving in calcified cysts. So after you rule out these three, then only you can start with antiparasitic agent albendazole. Sometimes if there are two cysts, we can add albendazole and praziquintol. But if there are multiple cysts, again the multiple cysts if you get, then it's also called Scarisky pattern. It is known as NCC encephalitis, and it is an emergency condition which you need to treat with pulse dose of prednisolone. Next is rickettsial infection, another very important, scrub typhus. Scrub typhus, usually even if you forget everything, you just remember what is the organism, that is Audientia. It's a Chiga-borne disease. And next you need to remember, we get a black eschar. Black eschar. So there are few differentials of black eschar. One you read in microbiology being the anthrax infection. It is not found, but scrub typhus is very commonly found. So in scrub typhus, what is the drug of choice? The drug of choice is doxycycline. Another very commonly asked question: if it is allergic to doxycycline, a child with doxycycline allergy or in a pregnant woman, what drug you're going to give? The answer will be azithromycin. So azithromycin if it is allergic to doxycycline, otherwise the drug of choice is going to be doxycycline. Next is SSP, subacute sclerosing panencephalitis. It is the most lethal complication of measles. So most lethal complication of measles. Usually, first we have the behavioral disorder. The child will come with behavioral disorder. In the stage 2, there is going to be myoclonic jerks. So first you are going to have behavioral problems in the stage 1. Next, you are going to have the myoclonus. Next, we are going to have the chorioathetoid movements. And last, we are going to have the child will result in coma. And there is no reversal because you can have two questions. Let me tell you the questions, then I'll just discuss it. We usually give isoprenosin, intrathecal interferon alpha, calcium, and we can also give the anti-epileptics because seizures are going to be there, and there is a negative myoclonus. So for this negative myoclonus, what is the preferred drug? The answer is carbamazepine. I'll also talk this in my neurology class. Carbamazepine is contraindicated in myoclonic jerks. Usually in pediatric population, we do not give carbamazepine. I think your medicine faculties or from wherever you're teaching, you're reading medicine from your guidebooks or whatever sources, you must be reading even in Nelson or in Harrison textbook, there you have indications of carbamazepine in the elderly, right? Like you have read about the trigeminal neuralgia, herpetic neuralgia, the drug of choice is carbamazepine, or sometimes it's congener oxcarbazepine. You have read the drug of choice in focal seizures is we can give carbamazepine. You must have read. But remember it from pediatrics point of view, we do not give carbamazepine because there are so many side effects. We do not prefer carbamazepine. Carbamazepine is actually given in two conditions in pediatrics. So it is contraindicated. It is not given, it is contraindicated in myoclonic epilepsy. So I'll just read tell this is very important. Two conditions in PED where you give carbamazepine, where we give carbamazepine as the drug of choice. One is Rolandic epilepsy, and another is SSP. In SSP also you have myoclonic drugs, but in SSP we give carbamazepine. So Rolandic epilepsy and SSP we give carbamazepine. Okay, so two conditions in pediatrics where we give carbamazepine are Rolandic epilepsy and SSP. Okay, so first question, what is the drug of choice of myoclonic drugs in SSP? The answer will be carbamazepine. Next, is there any cure for SSP? The answer is no. We need to counsel the parents. So, and you need to remember the full form, subacute sclerosing panencephalitis. So it is a lethal complication of which disorder? The answer is going to be measles. So slapped cheek appearance you get in case of parvovirus B19. In parvovirus B19 you also get, the Glavenstock's appearance, the arthritis, pure red cell aplasia, erythema infectiosum, right? But whatever you remember, slapped cheek appearance is parvovirus B19. Roseola infantum is found in HHV6, also in HHV7, but it's more commonly found in HHV6. Most common complication, already I told you about the most common lethal complication of measles, and most common complication of measles that result in death, the answer will be pneumonia. However, the most common complication of measles will be acute otitis media. So 3 questions. Most common complication of measles, acute otitis media. Most common complications of measles resulting in death, pneumonia. Most common lethal complication of most not lethal, I should say most lethal or most fatal. It's not most common lethal. Its most fatal complication of measles is SSP. So most common complication of mumps is aseptic meningitis. In children we can have meningitis with or without encephalitis. In adolescents we can also have orchitis. Most common complication of varicella is secondary bacterial infection. Since I have done 3 measles, mumps and varicella, let me also tell you, can you tell me what is the most common complication of pertussis? Because pertussis, the child will present with a URI symptoms, upper respiratory tract symptoms, where there is going to be cough, coryza, and the cough is going to be more in the evening hours and the night hours, and there is going to be a characteristic whooping sound. That is why we call it as whooping cough as well. So what is the most common complication in case of pertussis? Microbiology, the most common complication of pertussis, again it is pulmonary hypertension and secondary bacterial infection. So now you understand, in pertussis we go for an echocardiography because of what? In pertussis we go for echocardiography to rule out pulmonary hypertension. Okay. And pertussis, you need to see we usually see the PCR for Bordetella pertussis. Gold standard is definitely going to be culture, but the investigation of choice is PCR of swabs or washings, nasopharyngeal swabs or washings. So nasopharyngeal PCR is the investigation of choice in pertussis caused by Bordetella pertussis, and it is pulmonary hypertension and secondary bacterial infection. Now, few one-liners from tuberculosis. So, tuberculin skin test, what we call as the Mantoux test, is no longer done. No longer recommended in NTP. No longer recommended. Okay. Sometimes for latent tuberculosis we do the interferon gamma release assay, that is also nowhere mentioned. So the gold standard now we need to go for CBNAT. Okay. Cartridge based nucleic acid amplification test. So this is the gold standard. So suppose you get a child with low grade fever for 2 weeks, weight loss more than 5%, or weight loss in the last 3 months, and there is persisting cough for more than 2 weeks. Along with that, there is cervical lymphadenopathy. So you need to go for, first you need to go for a chest x-ray. And if in the chest x-ray, what is NTP telling me? So if you are having these symptoms, fever for 2 weeks, cough for 2 weeks, weight loss that is more than 5%, or no weight gain in the last 3 months, and cervical lymphadenopathy, first investigation use in tuberculosis is going for a chest x-ray. If the chest x-ray is not suggestive of anything of tuberculosis, but the child is having the symptoms, we are going to go for a 7 days antibiotic. We can give a 7 days amoxiclav as an antibiotic, and then we again call the patient and we go for a CBNAT. If the CBNAT is positive, then of course it's a microbiologically confirmed tuberculosis. If it is a negative and still we are having a deep suspicion, then it's a clinically confirmed probable tuberculosis. And suppose after this chest x-ray is suggestive, suppose there are some cavities, some hilar lymphadenopathy which are strongly suggestive of tuberculosis, we do a CBNAT. CBNAT tells you if it is a positive. CBNAT can be taken from either sputum or induced sputum or gastric lavage. So all these cases, if the CBNAT is positive, again it is tuberculosis. If it is a negative, then again we can do a repeat testing also. And the repeat testing also, if that is negative, then and if we have a strong suspicion, it's a clinically confirmed probable TB. If it is a positive one, it's a microbiologically confirmed tuberculosis case. From CBNAT we can also find out the resistance to rifampicin. So it's a first line probe assay which tells me whether it's a resistant to first line drugs, rifampicin resistant or not. So pyridoxine is given in all tuberculosis patient for along with INICET, okay, to prevent peripheral neuropathy. Now, steroids are implicated in which cases of tuberculosis? First is, remember, miliary TB. So it's a disseminated TB where we give steroids. Next is TB pericarditis. Number 3 is CNS TB. Mediastinal TB, laryngeal TB, Addison's disease where the cause is tuberculosis, TB uveitis. So these are the 6 important causes of giving steroids in tuberculosis. In neuro and spinal TB, it's usually have a bad prognosis. Okay, so what usually we go, we have an intensive phase and a continuation phase for each drug regimens in tuberculosis. Usually here the continuation phase is extended to 10 months almost, right? So in neuro and spinal TB, you need to remember that we give steroids. Steroids are given, that is dexamethasone are given before ATT, that is anti-tubercular therapy. And what are the new drugs? We have got the bedaquiline, delamanid, pretomanid, and these are cell wall synthesis inhibitor or mycolic acid inhibitor. So mycolic acid inhibitor, right? Now few points from which I would like to discuss from pediatric HIV. First is feeding. Exclusive breastfeeding or exclusive replacement feeding, but exclusive breastfeeding is preferred to exclusive replacement feeding. Usually in HIV children, we use HIV mothers who are HIV positive, and in HIV exposed infants we give options to the mother, that is either you go for exclusive replacement feeding, that is formula feed, or exclusively breastfeeding. Definitely we promote exclusively breastfeeding and mother's own milk in all occasions. When I'll be doing neonatology also, I'll talk about this, that is the best milk for a neonate, for a newborn, is mother's own milk, and there is no substitute to it. No formulas can take over that. Okay, but what in HIV you should advise the mother, there is no mixed feeding allowed. No mixed feeding allowed. Absolute contraindication of breastfeeding overall. Remember, only there are 3 contraindications, 3 absolute contraindications of breastfeeding. Number 1 is galactosemia. I already told you in my rheumat section that galactosemia is an absolute contraindication of breastfeeding. Along with that, we are going to get E. coli sepsis. It's going to be a very sick child with liver cell failure. Along with that, we are going to get oil drop cataract. So lactose intolerance. And the third is if the mother is on chemoradiotherapeutic drugs. Chemoradiotherapeutic drugs. And I'll talk in my NRP section as well that always we advise for delayed cord clamping. In HIV, we have to go for early cord clamping. So what are the antiretroviral prophylaxis that we have? We have the nevirapine. If nevirapine is not available, then it is zerovodine. So we start it at birth and we are going to continue it for 6 weeks. Usually zerovodine is usually given if it is HIV-2 positive, right? And in case of high risk patients like you, the mother was not on any antiretroviral therapy and the maternal viral load is not suppressed, or if there is no testing before 32 weeks, in all these cases we can prefer to go for nevirapine plus zerovodine, both. Vaccination HIV is an immunocompromised condition. So, you know, as I also talk about vaccination in special situations, you might be reading from your PSM point of view as well. All live vaccines are contraindicated in immunocompromised condition. Remember, either, so you can give all killed inactivated vaccines. So you can give killed inactivated vaccine. You can give rotavirus vaccine. You can give BCG, either you have given at birth or latter only you can give if the CD4 count is more than 25%. Measles you cannot give. Measles or MMR you cannot give. You have to start ART, and if anytime the CD4 count rises to more than 25%, then you can consider. Next is cotrimoxazole. You need to start from 6 weeks, and you need to from 6 weeks you can consider of birth. You have to give it till 18 months. Cotrimoxazole is another agent that you need to continue. And what is the investigation of choice is you need to go for a dried blood spot and you need to see the PCR. So you need to go for PCR in DBS, and that is the investigation of choice. There are many serological testings available also for HIV, but remember, in HIV, even if you're going for a serological testing, you need to confirm it by doing a PCR. So any newborn mother who is HIV positive, we call as HIV exposed infant. So either at birth we can go for a PCR, If it is not done, then at 6 weeks, we are going to go for a PCR. If the PCR is negative, you just observe. If the PCR is positive, then you repeat the test in 6 months. If the PCR is positive, if it was previously positive, then it's a HIV positive. If with the PCR is negative, you can just observe. Next test you can do it at 18 months or 3 months after cessation of breastfeed. In all these cases, the investigation of choice will be dried blood spot for PCR. Suppose you are going to go for a serotesting at any point, like 6 months you're going for a serological testing and serotesting comes out to be positive, again at 18 months or 3 months after cessation of breastfeed, you need to confirm it by a DBS. So pediatric HIV, if you have to taboo that the child is HIV positive, then you need to be doubly positive. So one PCR is not going to help, one PCR and two PCR. You need to do 2 PCRs. If you're doing a serotesting also, if it is positive, then also you need to repeat it by doing a DBS PCR, right? And from birth to 6 weeks, you're going to start with the nevirapine prophylaxis. And from 6 weeks, you need to start with the cotrimoxazole prophylaxis. And it's a exclusive breastfeeding is preferred over exclusive replacement feeding. But again, it is the mother's discretion that whether she wants to go for exclusive breastfeeding or exclusive replacement feeding. So this is a very short about the NACO guidelines. Now a few points regarding hepatitis. So let's revise the one-liners which we are going to say regarding hepatitis. So no chronicity is seen in hepatitis A. Acute liver failure in pregnancy is because of hepatitis E. Now let me tell you, most common cause of acute liver failure in Western world is because of drugs, paracetamol. Most common cause of acute liver failure in India is basically hepatitis A followed by E. There is no B. Now this is extrahepatic manifestations of hepatitis B. So we'll have vasculitis, that is polyarteritis nodosa. We can also have polymyalgia rheumatica. We can have MPGN and MGN. So these are the extrahepatic manifestations, and we can have Guillain-Barré syndrome as well. So extrahepatic manifestations in hepatitis B. If you do not remember anything also, at least you need to remember about that there is vasculitis. What is the protective antibody titer in case of hepatitis B? That is more than 10. So more than 10 is the one you need to remember. So whenever we are having a child, newborn whose mother is hepatitis B positive, so hepatitis B exposed newborn, what we are going to go, we need to give the routine hepatitis B vaccination, that is the birth dose, and then along with the pentavalent what we give. Apart from that, we need to give the immunoglobulin, and this immunoglobulin, hepatitis B immunoglobulin, should ideally be given within 12 hours after birth. In India, we practice 24 hours, but Nelson mentions it as 12 hours. So if one option in MCQ, the answer will be 12 hours. So most prevalent genotype of hepatitis C is genotype 3. And vasculitis, which is associated with hepatitis B, it is a very repeated question. It is essential mixed cryoglobulinemia. How do you assess hepatic fibrosis? Again, the answer is liver biopsy. If liver biopsy is not in the option, then the second best is magnetic resonance elastography. So liver biopsy, if it is not there, the next best will be magnetic resonance elastography. So that finishes my pediatric nephrology and pediatric infectious diseases in a nutshell. In the next marathon series, we are going to complete the rest of all. That is, we are going to take pediatric neurology, and we are going to see the pediatric gastrohepatology as well, and another marathon on pediatric neonatology, and we'll be left with the general pediatrics. I hope to complete it within July itself. Stay tuned for more updates and follow the previous YouTube links as well. Thank you. And let's play the game.